Thank you very much for the invitation. I'm here to present the ins and outs, or the gastrointestinal issues that are common in cystic fibrosis. So let me start my talk by telling you about my own CF journey. I grew up in a different country, so I did not know anything about cystic fibrosis growing up. I do not have friends with CF. I don't know anybody with cystic fibrosis. And the first time I heard about the condition was in medical school during, in textbooks really. And the first time I met a patient was during my pediatric residency in New York. At the time, I took care of a few patients with pulmonary exacerbations, and some of them will have abdominal complaints. But as already mentioned, I really had a better understanding of the disease when I joined Paul Clinton's laboratory during my fellowship in pediatric gastroenterology, and this is in UC San Diego. At the time when I first met Paul, he was, I think, a little bit surprised because I'm going to be doing research in his lab, and I'm a gastroenterologist. At first, he didn't know what to do with me. But being brilliant that he is, we embarked on a journey together to look at the role of bicarbonate in mucus secretion in the CF intestine in mouse models. Thank you. Thank you. And so this is a picture of my lab, and a couple of them are here also as speakers this weekend. So it was during my stint in research when we reported that bicarbonate is necessary in mucus release, in normal mucus formation and mucus release, and that a defect in CF in bicarbonate secretion, which is seen in cystic fibrosis, may have detrimental effects in mucus release and viscosity. And I was young at the time, and very young, and I was very excited with my research findings and my encounter with some CF patients that I decided to ask our CF team at Rady Hospital if I can be their gastroenterologist. And I was very fortunate. They said, okay, sure, you can join us. And so I've been with them from 2008 to present. And this is just a picture of our team. It is consisting of different specialists that take a look at different aspects of CF, patients with CF. And so for today, we will be discussing common GI conditions in CF, and we will talk about pathophysiology if known, and diagnosis and management. So let me start with a case of a boy who has prominent gastrointestinal and liver conditions. He is a 16-year-old male who is homozygous F508del mutation and has lung colonization with Pseudomonas aeruginosa and methicillin-resistant Staph aureus. I mean, I am taking care of him because he has a lot of GI issues. So first, he has oral aversion up to this very day, and still on gastrostomy tube feeds to meet his nutrition and hydration needs. He is also pancreatic insufficient and is on pancreatic enzyme replacement therapy, which fortunately, with combination of this gastrostomy tube feeds and pancreatic enzymes, probably made him reach his goal of body mass index at the 50th percentile. Previously, he had been failure to thrive prior to his G-tube placement. His symptoms are very prominent. He complains every clinic visit of early satiety, abdominal pain, and intermittent abdominal distension. And he has chronic constipation, needing much more than the non-CF patients that I usually take care of. He needs Miralax 17 grams or 1 capsule 3 times per day to achieve regular stool movements or bowel movements. And on examination, he has splenomegaly, which is about 6 centimeters palpable. The spleen edge is palpable 6 centimeters below the left costal margin. He also has elevated liver enzymes with ALT in the 60s and elevated GGT. And on blood count, platelet count is about 50,000. Normal is about 150,000. And because of these findings, we had a very low threshold for looking for. We thought maybe he had signs of portal hypertension, so we did some endoscopic surveillance, and it was not very surprising that he was shown to have varices and portal gastropathy. So GI issues in cystic fibrosis is very common. And this Siri also mentioned this yesterday, that when they did a survey, CFRI did a survey, that GI symptoms are actually even more common than pulmonary symptoms as reported by CF patients. And in 2017, there was a survey, a study that surveyed patients, CF patients, and interestingly, all of them, 100%, report abdominal symptoms in the preceding 3 months of the study. And the most common symptoms were lack of appetite, loss of taste, abdominal pain, flatulence, and abdominal distension. And unfortunately, GI complaints arise very early, so may arise very early in the course of the disease and may have significant impact on quality of life of these patients. And it may have significant disease outcomes, and including but not limited to growth and attrition, pulmonary function, and again, quality of life or patient perceived wellness. You are all very familiar with this basic pathophysiology of CF. CF is the most common inherited lethal disease in the Caucasian population and caused by the CFTR gene mutation. And because of this defect in CFTR, there is, it's very prominent that patients have viscous and acidic secretions, and this is due to deficient chloride and bicarbonate secretion through the channel. And this causes partial or complete obstruction of various hollow organs, including the gut, biliary ducts, and pancreatic ducts, and may have associated increases in local and systemic inflammation. So I decided to talk about pancreatic insufficiency in ADIS because this is very common in CF, and more than 85% of patients are affected. Damage occurs because of this sluggish flow of the pancreatic secretions or enzymes through the ducts. And because of trapping, there is premature activation in the cells, causing damage to the pancreas, leading to insufficiency. And this damage can occur as early as 17 weeks of gestation in utero. Therefore, a lot of patients are born with pancreatic insufficiency. Symptoms are really, symptoms of malabsorption, failure to thrive, abdominal distension, and loose greasy stools. And obviously, there are long-term consequences of malnutrition if not detected early or not treated early, such as permanent short stature, cognitive dysfunction, particularly due to vitamin E deficiency, and rapid decline in pulmonary function. So diagnosis, when you look at literature, everybody says traditionally the gold standard is a 3-day measurement of fecal fat. However, this is very cumbersome. So what you do is you ask patients to eat at least 100 grams of fat per day, and then you collect all their stools for 72 hours. So malabsorption absorption of less than 93% of fats that are ingested, or more than 7 grams of fat per day in the feces, is diagnostic or suggestive of pancreatic insufficiency. However, this is very cumbersome. I don't know how many of you will do a 3-day fecal collection. And I think particularly hard for patients who are, who are in diapers, because it will just, go through the diapers. It's hard to do. So this has been largely replaced by fecal elastase testing. So elastase is a pancreatic enzyme that is secreted in the pancreas, and it doesn't undergo degradation into the GI tract, so that you can actually measure the elastase in the feces. And as most of you know, pancreatic insufficiency is described as less than 200 micrograms per gram, a result of that. And in severe ones are classified as those with less than 100 micrograms per gram of elastase in the feces. Another one is secretin stimulation test. This one is very invasive. So what you do, this is done endoscopically. Essentially, while the scope is inside the body of the patient, you stimulate with secretin, which stimulates pancreatic enzyme secretion, and then you collect the duodenal juice, measure the pancreatic enzymes in the duodenal juice, and that's how you look if there's sufficiency or not. However, again, this is very expensive and invasive, and with the fecal elastase test that we have, which almost nearly is 100% sensitive, this has been also almost not done. And in fact, I've only done this twice during my fellowship training. Management is use of pancreatic enzyme replacement and supplementation of fat-soluble vitamins, vitamin A, D, E, and K. So I looked at the CFF Patient Registry Annual Data Report of 2017, and it is not surprising that about 90% of patients, especially in the younger population, are on pancreatic enzyme replacement therapy. The reason why it seems like it's going down is because I think that the life expectancy of patients who have milder mutations, those who are pancreatic sufficient, they reach a longer, they live longer, and so the rate of enzyme replacement therapy drops in the registry. And also the registry removes all patients that are post-lung transplant. Just a few notes on pancreatic enzymes. They are porcine-derived. It consists not just of lipase, but it also has amylases, which digest carbohydrates, proteins, which digest proteases that digest proteins, and lipases that digest fats. And it's given at the start of meals and snacks, and it's usually weight-based dosing for those who are greater than 2 years old. And for infants, we use the amount of milk that is ingested. For those patients who are continuous gastrostomy tube feedings, there is really no ideal dosing. And I think different centers do different things. At least in our center, we do give them prior to the start of nocturnal feedings. Other centers would do it also in the middle, and others would do it at the end as well. But I think nowadays we have the availability of this lipase-loaded cartridge that can be used for continuous feeds so that emulsification of fats continue as the feeds are ongoing at night. More things about pancreatic enzymes is the fact that you actually need to take it as directed. So they are microencapsulated beads that should not be crushed to prevent inactivation of the enzymes within. And there is an acid-resistant film on this that prevent premature activation in the stomach. So ideally, the pancreatic enzymes should be activated when it reaches the duodenum, which has a higher pH. And therefore, in CF, bicarbonate usually causes the increase in pH in the duodenum. But in CF, because of the defective bicarbonate secretion, one may not reach the appropriate pH. And so there may be some delays in activation of these enzymes. And therefore, some advocate the use of acid suppression medications so that, to decrease the gastric acidity such that when the enzymes actually reaches the duodenum, it is already in an optimal pH for activation. I'm going to talk about pancreatitis. This is not very common. Actually, it only presents in about 1% of CF patients. However, I think with the advent of CFTR modulators, there are some patients who convert from pancreatic insufficiency to sufficiency. And therefore, if you see patients with abdominal pain, you also have to think about pancreatitis. So pancreatitis usually happens more. It's more likely to happen in pancreatic sufficient patients. About 10% of pancreatic sufficient patients, and only 10% of CF patients are pancreatic sufficient, and therefore the 1% that I was mentioning. For you to get pancreatitis, you need some functioning pancreatic acinar cells, because the mechanism of pancreatitis is that there is, again, premature activation of the enzymes within the pancreatic cells. And this happens because of the slow ductal flow within the pancreatic ducts. And therefore, instead of it going directly into the duodenum at the optimal time, it stays longer in the pancreas and it activates there prematurely, causing the damage. Therefore, it usually only happens to those patients who are pancreatic sufficient. And the thing about pancreatitis is that it's not just a localized inflammation. There could be systemic inflammation leading to multi-organ failure. And in severe cases, it can also cause death. So pancreatitis, though, is you need to have a high index of suspicion. So when a patient presents with abdominal pain, you may need, and they're sufficient, you may need some to check lipase levels. Although it's a little bit hard to diagnose because the lipase level may not actually reach high levels that are seen in non-CF patients. Typically for pancreatitis, you need to have elevation 3 times upper limit of normal. But it's barely achieved in CF patients, and therefore you really just have to have a high index of suspicion for those patients. The management is similar to non-CF patients. Cornerstone of management is hydration and pain management, and preferably non-narcotic analgesics, because narcotics typically causes this decrease in intestinal transit and can cause constipation and DOS, which I'll talk about later also. So nowadays, we advocate for early reintroduction of feeds, even during an active pancreatitis episode, as long as the patient is stable. And I put here question mark the use of ursodeoxycholic acid. It may have, there's really no study on this, but it may have some benefits to prevent biliary cholesterol formation and stone formation. Prevention is really, in adults, avoidance of alcohol, and if possible, decrease the use of medications that may cause pancreatitis, but I know that this is not always possible in CF. So another big one that is very common is gastroesophageal reflux disease. And depending on what study you look at, it can be a third to majority of patients with reflux, who have reflux in CF. And the higher range is really using 24-hour pH probe measurement, which is the gold standard for diagnosing reflux. More than half of CF patients, regardless whether they have symptoms or not, have abnormal 24-hour pH probe measurement. And in that study, 91% of CF patients awaiting lung transplantation have reflux, and up to 90% of post-transplant CF versus 54% in other end-stage lung disease. Therefore, it appears that the prevalence of reflux in GERD is higher than general population in other chronic lung disease. And the registry in 2017 report, this is per patient report, is that they have about a third or a little bit more than a third of patients report reflux. I think it's both physician and patient reported. And just to let everybody know that the registry accounts for nearly 30,000 of CF patients in North America. And it's more common, this is more, the incidence is higher than other GI complications outside of pancreatic insufficiency. Predisposing factors, these are the proposed factors or risk factors for reflux in CF. Airway hyperinflation causes increased negative inspiratory pressure, allowing for reflux to happen. Reflux is really when stomach contents go into the esophagus, which should not be seeing acidic environment. And frequent coughing of patients may cause reflux. High-fat diet and hyperalimentation. High-fat diet has been associated with delayed gastric emptying, although gastric emptying in CF patients are also controversial. There's no really, some studies show accelerated gastric emptying, some studies show delay, and some show normal gastric emptying. So I think that this is still an area for research, and possibly positional changes due to physiotherapy. The treatment is similar to non-CF patients. There's really no guideline for reflux treatment in CF. So essentially, we use diets that are more, that do not induce reflux, such as avoiding spicy foods, avoiding greasy foods, avoiding overeating, and even eating late at night if you can. And acid-reducing agents are commonly prescribed. There are two big classes, the proton pump inhibitors and histamine 2 blockers are used. But in the absence of symptoms, as I mentioned, there are some patients that may have reflux on pH probe monitoring, but they really have no symptoms. Invasive testing is not really warranted. And once treatment is indicated, whether with PPIs or H2 blockers, we need to have regular assessments, just because these medications are not necessarily risk-free. And so this is the use of PPIs and H2 blocker. PPIs are more commonly prescribed in cystic fibrosis. And in fact, more than half of the patients are on PPI. But this data accounts for both use of PPI in GERDs, in reflux, as well as increasing efficacy of pancreatic enzymes. Problem with PPI in CF is that there are concerns about risk or increase in pulmonary exacerbations. There was others also, I think, possibly concerns about risk, increase in, C. diff colitis. However, there has been, so far, no significant correlation has been found with the use of PPI. I mean, more than 50% of patients may have colonization of C. diff, but it doesn't necessarily mean that they have an active inflammation or infection. And a poor bone density that has been a hot topic even for non-CF patients, whether they truly can cause premature osteoporosis. At least this is what I found in literature, that there was a retrospective study in CF children in Cincinnati Children's, wherein, again, retrospective study, so they looked at the PPI group, which is described as CF patients on PPI for at least 6 months, and the control, which are CF patients who have never been on PPI. And the only significant thing that they found was that there was an increase in pulmonary exacerbation on those PPI-treated group. Fundoplication. So there is a surgical treatment for reflux. So I mentioned medical management, but there is a surgical treatment for reflux. And in fact, there is they have found significant decline in pulmonary exacerbation and improvement in FEV1 for 2 years after fundoplication. So essentially, fundoplication is when you use the upper part of the stomach and kind of wrap it around the lower esophagus to decrease the relaxation or transient relaxation that the esophagus does during reflux episodes. However, it is not without risk. Again, it's a surgical procedure. You have problems with healing. You may have problems with dysmotility after. Some patients describe difficulty swallowing after the fundoplication, depending on how tight it is. And there are patients that cannot burp, so they chronically have these symptoms of bloating. However, and also the other thing is that even after fundoplication, there may be a recurrence of reflux symptoms in about half of the patients. Problem is, when you may probably go back in to do another, it's just technically very difficult to do that, and a lot of surgeons discourage us from having a repeat fundoplication. So moving on to this distal intestinal obstruction syndrome, which I'm sure a lot of you have heard about. It is more common in pancreatic insufficient patients. Those patients that have history of meconium ileus as infants, or those with prior episodes of DIA. So once you have it, you have the risk of recurrence. And adults are more commonly affected, more than 7 times compared to children, and those who are post-lung transplantation. Symptoms are also very nonspecific. You may have abdominal pain, but particularly in the right lower quadrant, distension, anorexia, with or without vomiting, depending if you are how obstructed you become. So this is the area where the obstruction happens. This is on the right side of the abdomen. And interestingly, this is also the area where appendicitis pain usually happens. And in fact, we just recently had a case wherein the patients, I think, presented with DIAS, but the ER thought that the kid had appendicitis, the CF kid had appendicitis and underwent appendectomy. I mean, whether or not it helped with resolution of her symptoms, because eventually we even had to lavage her too, is unknown. Diagnosis is based on patient symptoms. Sometimes you may feel a palpable mass in the right lower quadrant because this area is full of stools. and an abdominal X-ray, which also shows that the predominance of stools in this side. There are two types. So you can have a complete obstruction. Definitely treatment for this is hospital setting because this may present with high-grade obstruction, such as the patient is vomiting, not tolerating anything, has significant distension. Definitely surgical consultation has to happen early on. And we put nasogastric tube to decompress the bowels. We give them IV fluids and definitely pacing the patients, nothing by mouth, no eating. And we attempt to clear the obstruction using enemas from below. So we may use hyperosmolar contrast. It may need repeated applications to relieve the obstruction. Some studies have also shown that N-acetylcysteine enemas to be beneficial. And surgical intervention if medical management fails, or if patients present with necrotic bowels, which may happen. Fortunately, most of patients with DOS actually present with incomplete obstruction. And for those patients, they may have the right lower quadrant pain, distension, but they can be treated with lavage from above, from the nose. Usually we put a nasogastric tube, and we lavage with high-volume polyethylene glycol solutions. And in some patients who may tolerate it, oral laxatives or enemas, although I haven't seen this very effective in the inpatient setting, because they usually have decrease in appetite, obviously because of symptoms. And the prevention there's no clear preventive strategies for DOS. What we know is that adherence to pancreatic enzymes and reassessment of dosage may help, just because if you have malabsorption, some of the proteins and fats can mix with the thick mucus secretion causing DOS, and therefore the thought is that when you adhere to your enzymes well and you have the proper dosage, that you may have less malabsorption and therefore less chances of developing DOS. Also, avoidance of dehydration, although this is sometimes hard when you have pulmonary exacerbation and you really don't have the appetite to eat anything, or your post-surgery. And what we do usually is for those patients that develop DOS first time, or those with history of meconium ileus, we consider regular or intermittent use of oral laxatives. So a lot of them will be on this. Interesting, though, is that even though I know most of you have heard of this syndrome before, it does give, when patients are presenting with this, it is very painful and very distressing for the patients and families. But fortunately, it only happens in about 2 to 3% of CF patients. It's not very common. This is contrast this with constipation. So as I said, that DOS usually happens in the right side, whereas constipation commonly is accumulation of stools in the left side. The difference is that the definition of constipation is when you have abdominal pain, distension, or both, and you have a decline in frequency of bowel movement. So let's say your usual bowel movement is 2 or 3 times per day, which are common for CF patients, and they suddenly drop to 1 time a day. In non-CF patients, you may say, oh, that's fine, you're still defecating every day. But for our CF kids, we're hyper vigilant about this, and we tell them to take their enzymes their laxatives, just because we are afraid of DOS and constipation, even though they're pooping frequently. But as long as it's less than their usual amounts. And increase in consistency of stools are also one of the things that is defining constipation, and that those symptoms should be relieved by laxatives. And the reason why constipation is common is because of intestinal dysmotility that is seen in CF patients, possibly decreased water secretion and abnormal mucus. Again, tying it all up to the basic CFTR defect. And it is not necessarily associated with the severe genotypes. Diagnosis is clinical. We usually discourage taking a lot of abdominal x-rays just to decrease the burden of radioactive exposure. And there is no, interestingly, is that in CF patients, it has been shown that constipation has no correlation with how much fiber you eat and how much water you take. Doesn't matter. I mean, this is in contrast to the non-CF patients wherein increasing their fiber and increasing their fluid intake may help with constipation, but this is not necessarily seen in CF. Treatment usually is polyethylene glycol, whether on a daily basis or as needed, and stimulant, plus or minus stimulant laxatives for those patients that are known to have this motility. Now, lubiprostone is an adjunct treatment for those patients who are not responding well to these two laxatives. Lubiprostone, as you know, has effects on CFTR and type 2 chloride channels, and so it increases chloride and fluid secretion. And in CF patients, it has been found to may be of benefit. And in fact, we use this on some of our young or older adolescents who present with very difficult to treat constipation, and most of them actually respond. Small bacterial overgrowth. Again, this one, this is when excess bacteria goes into the small bowel. Typically, most of the bacteria in the gut occurs or reside in the colon. But then when they reach the small bowel, it can cause symptoms of abdominal bloating, pain, diarrhea, flatulence, with associated malnutrition and malabsorption secondary to the inflammation that happens in the small bowel, which is really the site of absorption. And the risk factors in CF is possibly because of the lower pH of secretions. Again, this motility, if you have stagnant or stasis of a chyme in the small bowel, you may have higher rates of SIBO, ingestion of pulmonary bacteria, reduced mucosal host defenses due to intestinal inflammation, and possibly also treatment-related. So the use of proton pump inhibitors, chronic antibiotic use, which may cause dysbiosis in the gut, and previous intestinal surgery, just because, when you have scarring or adhesions in your gut, you may have a little bit more stasis in the small bowel compared to normal. And as I mentioned, because of its effect in the small bowel, which is the site of absorption, you can have malnutrition and anemia. The problem with SIBO is that it is very hard to diagnose. And in fact, I must admit that most of us, or at least in our center, if patients present with symptoms of malabsorption and we already are maximal on pancreatic enzyme replacement therapy, we put them already on PPI to increase efficacy of PERT, that we actually try to just treat empirically for SIBO. Just because the diagnosis, which is the gold standard, is a culture of duodenal aspirate. What again this means is that you scope a patient, put the scope inside, you get duodenal juice, and then you quantitatively culture the fluid, which in strict definition, SIBO is when you see greater than 10 to the 5th colony-forming units per ml of duodenal fluid, and usually has to be predominantly colonic or anaerobic bacteria. This is very hard to do because high cost, again, you have to put patients under anesthesia, it's invasive, and not a lot of laboratory can do quantitative cultures of bacteria. And in fact, I'm in San Diego, our hospital cannot do this, unfortunately. And so we have to send it out. So it's cumbersome. The other thing is the hydrogen and methane breath test, which are mainly the ones that we use for for diagnosis of SIBO. What this means is that patients are asked to breathe in a tube after taking in some sugar substrate, such as glucose and lactulose, and then they measure the hydrogen and methane in the breath, which is presumed to be elevated in patients with SIBO, just because those bacteria produce hydrogen and methane. Again, for breath testing, patients have to be no antibiotics for 2 weeks, no probiotics for 2 weeks, and therefore, because it can change the results of the study, and therefore, again, very hard to do in CF patients. Therefore, that's why I said empiric treatment sometimes is what we resort to. And treatment usually is just oral antibiotics. You use them to target the usual intestinal flora, So we use rifaximin, metronidazole, or amoxicillin clavulanic acid. So probiotics have been, I guess, very popular nowadays. Problem with probiotics is that it has limited bactericidal properties. But it will likely compete with the pathogenic bacteria. So the good bacteria, you essentially try to restore better balance between the good and the bad bacteria. But it may not necessarily kill those already there. So oral antibiotics is really what we use. And perhaps, although may need human studies, the use of laxatives and N-acetylcysteine, which were seen to be effective in mouse models, essentially just lavaging the inside. Maybe you can push the bacteria out of the small bowel. But this really needs human studies. So I'm going on to gastrointestinal cancers, although I would like to mention that, again, I'm a pediatric gastroenterologist. So we really see this in the pediatric population. But I would like to discuss this because it has been found that CF patients have an increased risk for esophageal, gastric, hepatobiliary, gallbladder, small intestine, and colonic cancers. Especially since the survival of CF patients seem to be, for the better, getting longer. So we are seeing cancers happen. And the postulated reasons for the increased risk in cancer is due to CFTR inflammation, defective mucus function, and perhaps deficiencies in antioxidants. Lack of omega-3 and vitamin E perhaps may be causing an increased risk in cancer. And for those patients that are a post-solid organs transplant, they have immunosuppressants, which also increases your risk for cancers in general. So because of these, colorectal cancer screening guidelines have been suggested or recommended. And what has been found in all literature is that CF patients who develop colorectal cancers get them before age 50. So in non-CF population, we usually see them greater than 50 years old. So you can see that there's a shift. So CF patients get them earlier. And incidence of colorectal cancers in CF occur those CF patients who are 40 to 49 years old have similar incidences as those 65 to 69-year-old in the non-CF population. And therefore, there was an 18-member colorectal screening task force that was convened in 2015 at the CF headquarters, and they made these guidelines. So there are 10 consensus recommendations in CF that was put forward last year. And that number 1, I'm going to read them. All decisions of colorectal cancer screening and surveillance be based on shared decisions between the provider and the individual with CF about treatment, comorbidities, safety, and quality of life. And that they should be jointly managed by CF healthcare professionals and an endoscopist. And that screening should be done via colonoscopy. So the other screening modalities that like fecal occult blood testing and CT scans are really insufficient to use as screening modalities. And that screening begin at age 40 and that you were screened every 5 years. So this is in contrast to a non-CF population. Historically, many, many years ago, our screening guideline for non-CF patients are age 50 and above, although a few years ago, they changed this to 45 years old. But in CF, it has to be 40. And that if you find a polyp that may be precancerous or adenomatous, that you have to repeat it not in 5 years, but you repeat the surveillance in 3 years, unless a shorter indication is needed based on current findings, meaning to say if there's high-grade dysplasia, really you're worried about cancer, that you have to do it before 3 years. And for those with solid organ transplantation, once they recovered, they use even a more stringent age cutoff of 30 years old after solid transplant, once they recovered, to have screening within 2 years of the transplant, unless they have negative colonoscopy within the past 5 years. And that the continued screening happen every 5 years, who receive solid organ transplant, and again, with those transplant and those with polyps, to have a screening every 3 years or earlier as needed. And interestingly, too, that they say that the recommendation is that in adults undergoing colonoscopy to have intensive regimens for bowel preparation, which means they recommend at least 4 washes. So at least 1 liter each wash to make sure that there's optimal examination of the lining, just because there's the secretions and constipation. So you have to be more aggressive with cleanouts. I'm going to touch also on liver disease and cystic fibrosis because it is, it is common. I mean, it's not that common as pulmonary complications, but it is the 3rd leading cause of mortality in CF. And CFLD, or cystic fibrosis liver disease, is really an umbrella term to describe different liver conditions that arise from a patient having CF. Problem with CFLD is that there is no single diagnostic test to diagnose, and in fact, we are still debating as to what the definition of CFLD is. But the screening recommendation is to have annual physical examination and liver function test. And I did say plus minus abdominal imaging because as of to date, we don't really have a consensus on what kind of imaging modality to use. So in the registry, we did see, again, it's not a lot, but there's still significant numbers, like 5 to 10% of patients will develop significant liver disease, and usually happens during childhood. Interesting, though, is that we see a lot of children with abnormal ALT. Up to 40% of them will have abnormal transaminases by 12, but not all of them will develop significant liver disease. Some of them will just have this elevation maybe for life, and nothing really happens. And some of them, about 5 to 10%, will develop liver cirrhosis and significant portal hypertension that is associated with complications. I just would like to say, though, that the height of elevation of transaminases do not really correlate to the progression of portal hypertension, meaning to say that even though you only have a slight elevation, it doesn't mean that you're not going to progress to portal hypertension, which also makes it very challenging for us to identify those patients who need to be, who need very constant or close supervision or surveillance. Complications of cirrhosis, as I mentioned. So varices is one. Varices is when you have, when you shunt some of the blood flow into the intestine and it goes to the path of least resistance into the esophagus. You see actually very fat vessels in the esophagus that is prone to bleeding. And when it bleeds, it may be very hard to control, such that we usually want to see them early on so that we may possibly institute prevention strategies to prevent it, to prevent bleeding. Gastric varices are also seen, and as I mentioned, splenomegaly. And splenomegaly is, it is an enlargement of the spleen, but if the spleen is very large, and I actually have seen a patient like this, it affected the rest of his gut, meaning that, he has early satiety, he just really can't eat well because he feels nauseous all the time because the spleen is occupying a large portion of his abdominal cavity. And the spleen is responsible for, removing your, dead blood cells or damaged blood cells, such that when you have enlarged spleen, you can also see lower platelet counts because they just eat them up faster than usual. And that's why, as I mentioned earlier, low platelet count is also a sign that we look for when we're looking for complications of liver disease. And as I mentioned, you cannot predict those will have significant disease, liver disease. Suspect when you have low platelet count, splenomegaly, and slight elevation of transaminases. It's very, I would like you to be aware, though, that transaminases elevation varies depending on the laboratory that you look at. So, but really there is a safety study that was done by my colleague, Dr. Schwimmer, and at least in pediatrics, our cutoff is 22. So it's 26 in females and 22 in males. And therefore, just for, I guess, easy to remember, we ask our pulmonologist to refer patients who have persistent liver enzymes above 30. And just this last week, I saw a patient who, I guess, was not recognized because the laboratory where she goes to has a cutoff of 70. And so she has been, have ALT in the 60s for many, many years, but it's not flagged because the lab has a 70 cutoff, which is really not right. Problem is that liver biopsy remains the gold standard for diagnosis. Liver biopsy, as you know, is invasive. It requires patient to be sedated or under anesthesia, and therefore we don't necessarily use this a lot unless we're really thinking that patient, if patients should be referred for liver transplantation. And sampling error may happen with liver biopsy, such that you need to have at least 2 passes because of sampling errors. And may be helpful, as I mentioned, ultrasound with Doppler. Problem with ultrasound is that even if you have normal ultrasound, it doesn't necessarily mean that you don't have significant liver disease. And likewise, if you see abnormal ultrasound showing heterogeneous findings, it doesn't necessarily mean that you're going to progress to bad liver disease. So I don't know. I think we use this just really to quantify the size of the spleen. And the other one is transient elastography, which looks at stiffness of the liver, which could be a sign of fibrosis. However, there are no standards, or really standards, what is normal in different ages, in different age groups. So it's very hard to interpret. And I say referral to a pathologist if you really have a suspicion that the patient is progressing to a significant liver disease. So as of this time, we really don't have, unfortunately, we don't have any we don't have a lot of options for pharmacologic management of this condition. We have ursodiol, ursodeoxycholic acid, which theoretically can improve biliary secretion and has hepatoprotective effects. There is a good safety profile if you use the mid-range dosing. However, there's no long-term outcomes on if they can prevent transplantation or progression of liver disease. So a lot of centers actually use this just because we have no alternative. And avoidance of hepatotoxic medications if possible, which is, I know, is not very possible in patients, especially when you're faced with pulmonary exacerbations, and avoidance of alcohol use and liver transplantation for those with end stage. Just showing you that the use of ursodiol is about 20%, and usually in the younger age group, because as I said, this is usually when we see findings of CFLD. I don't know if we have time, but briefly, this is really just a few slides on nutrition. Your dietitians may tell you that you have to eat a lot, energy intakes of up to 200 or double the amounts for healthy patients of similar age, sex, and size recommended, just because we need to maintain a BMI of greater than 50% for pediatric patients, and BMI at or above 22 in women and above 23 in men. And this is because it has been associated with better FEV percent predicted. As you can see, this is again data from the registry that if you achieve 50th percentile in pediatrics, that your FEV1 is much better. And similarly, in adults, you also see the same findings, that if you reach this goal of BMI, that your FEV1 is better, will be better. There is still a lot of research on unmet needs in the GI tract, and even though it's a very common symptom in CF patients, there's really not a lot of studies ongoing. There are some, but it's not mainly the focus at this time. But there's still some things in your wish list. Can we have alternative to porcine enzymes for those with pancreatic insufficiency? Just because the burden of pills that you take in every day with your meals is massive, especially for the pediatric population. For DOS, is there any way that we have effective preventive strategies, and can we standardize treatment? For liver, can we have standardized ways of diagnosing so that we can study it further? And then also, treatment and prevention, and is there any drug that is superior to ursodiol? And I think that now that we're in the era of CFTR modulators, I think we need to see or study more the GI, liver, and pancreatic effects in CF. And I think it deserves attention, certainly when looking at outcomes from new therapies. And I know yesterday Dr. Rowe talked about improvement in pancreatic condition in patients G551 with ivacaftor, but then we still need to know, so far in our center, we haven't seen any severely pancreatic insufficient patient convert into sufficiency. I mean, we have a few that are on the borderline that convert, but then once you hit severe insufficiency, we haven't seen any success stories so far yet. Now, I just would like to end my slide with what my 5-year-old daughter said. This is also her drawing. She said that, "I wish there are no more sick kids in the world." Very insightful for a young kid.